This is Module 3, Principles of Radiation Dose and Risk. Please take time to look through the anticipated learning outcomes from this entire module. At the end of the module, we hope that you will have achieved an understanding of the nature of X-rays as a form of ionizing radiation, an understanding of the ways in which X-rays interact with matter, including absorption and scatter, an understanding of the concept of and the difference between stochastic and deterministic effects, a knowledge of what is meant by the dose of X-rays, how to calculate it, and an understanding of the SI units of radiation dose. We would also want you to gain an understanding of how dose relates to the risk of stochastic effects. In terms of skills and abilities, dentists are not practitioners of dosimetry, so the main skill and ability that we hope you will have achieved is an ability to communicate the risk of radiation to others effectively. And in summary, in terms of judgment and stance, we hope to achieve an evidence-based understanding of radiation dose and risk that can be communicated to other people, principally your patients, in easily understood language. First of all, let's look at the nature of X-rays. X-rays are a form of electromagnetic radiation. Looking at the image on the right, you'll see the electromagnetic spectrum of radiation. Within this are many familiar forms of radiation, notably visible light, but you'll also see microwaves, radio waves, and so on. These different forms of radiation differ in two respects, in their frequency and in their wavelength. Otherwise, they are very, very similar. X-rays can be seen up at the top of this spectrum, and here the radiation is high frequency and short wavelength. Just above X-rays you'll see gamma rays, and although here there is a difference in frequency shown, in fact there is very little difference between these two forms of radiation. Gamma rays are simply naturally occurring, X-rays are man-made. At this high frequency end of the spectrum, it's important to understand that high frequency means a large amount of energy is contained within the X-ray photons. And that brings us nicely to the subject of the photon. When you X-ray a patient, or you are X-rayed yourself as a patient, many little packets of energy pass through the body. Each little packet of energy is called a photon. This term photon also applies to visible light and all the other forms of radiation that we just looked at. Each photon exerts an electrical and a magnetic field, hence the name electromagnetic radiation. However, this is not very important in terms of radiation protection, so you can safely forget about it at this stage. What is important is that you understand that each photon can impart energy to atoms and molecules by collision when they pass through them. How do X-rays interact with matter? Well, there are two principal ways in which this occurs: absorption and scatter. In absorption, the X-ray photon hits some material and its energy is absorbed. Very simple. Alternatively, the X-ray photon might pass through a material and be deviated in its path, sometimes with loss of energy, sometimes without loss of energy. Finally, X-ray photons can pass completely through materials without any interaction at all. Looking forward to a clinical context, this is of course important because if all X-rays were absorbed or scattered when they pass through material such as a patient's body, then you wouldn't get any image. We'll start off by looking at the radiograph on the top right. This is just a very familiar bite-wing radiograph. The frequency of absorption, scattering and transmission of X-rays depends on the material through which the X-rays pass. If you look at the lower left 6, you will see that there is a very radiopaque, white appearing restoration. This is radiopaque because it's absorbed lots of radiation, and this reflects its high atomic number. Similarly, the occlusal restorations in the lower left 7 and the center of the upper left 6 are dental amalgam, and these also contain high atomic number materials which absorb X-rays particularly well. Contrast this with the composite restorations in the mesial of the upper left 7 and the rest of the upper left 6. These materials have lower atomic number materials and therefore do not appear so radiopaque. In another context, the picture on the bottom right shows a sialogram, a picture of someone's salivary gland produced by injecting a highly radiopaque liquid into the parotid duct. The highly radiopaque material is iodine, and iodine has a high atomic number. As we said, the frequency of the interactions between X-rays and matter depends upon the atomic number, but it also depends upon the energy of the X-ray photons. Low energy X-rays are more likely to undergo absorption, whereas higher energy X-rays produce more scattered radiation. In a dental context, we can think of this in terms of a very low kilovoltage X-ray set, in which case you get more low energy X-rays produced, which are more likely to be absorbed. A more modern, higher kilovoltage X-ray set will produce higher X-ray energies and more scattered radiation. Regardless of whether we have absorption or scatter, we must understand that energy is being transferred to the material. And this energy can be sufficient to remove electrons from stable orbits in atoms and produce what is called ionization. Putting it diagrammatically, we can see the effect. An electron is removed from an orbit in an atom, producing ionization. Of course, if this happens in an inanimate object, such as a patient's filling or a lump of wood, this has no effect whatsoever of importance. The problem occurs if this arises within living tissue. Here, ionization has the potential to cause significant damage. Although any molecule within a cell could be damaged, we tend to think most about a very important molecule within cells, the DNA. An X-ray photon could directly impact on a DNA molecule and cause damage to it by ionization. Alternatively, an X-ray photon may interact with the commonest molecule in any cell, water, and break this molecule up into reactive radicals, which in turn can go on to damage the DNA. We want to move on now to look at doses of radiation. We talk about the dose of an X-ray examination, but it's important to understand something about what this actually means. Remember again that when we X-ray an object, we transfer energy from the radiation to the atoms. So a simple way of quantifying the dose of radiation is to talk about the energy absorbed per unit mass. And using conventional SI units, this means that the logical unit of dose would be the joule per kilogram. In a radiation context, 1 joule per kilogram is traditionally called 1 gray. And this is called absorbed dose. Try to remember this term because we have a number of different ways of expressing dose. Unfortunately, things aren't that simple. Different types of radiation have different damaging potential for the same dose. This is rather a confusing subject, perhaps overcomplicated for our purposes, Nonetheless, it's important just to mention it. Some forms of radiation, such as alpha particles and protons, can exert far more damage for the same dose of radiation than do X-rays or electrons. This means that weighting factors have been allocated to them according to their potential to cause damage. And we have this second form of dose called equivalent dose, which is the absorbed dose in grays times this weighting factor. This means that our unit of dose changes its name to the sievert, abbreviated to capital S, small v. Unfortunately, the story for dose doesn't end there. Consider this. If you X-ray someone's abdomen, for example, you will be getting a different biological effect to if you X-ray someone's head or face like you do in dentistry. The reason for this different effect is that different tissues have different radiosensitivities. Our bodies are not homogeneous. Different tissues and different materials are inside us. The table here shows weighting factors that have been allocated to different tissues and organs within the body according to their calculated radiosensitivity. This brings a new type of radiation dose concept to us called effective dose, really dealing with the risks associated with a particular dose of radiation. If you look at the table, you will see here tissues that are associated with X-raying a patient in dental practice perhaps. Red bone marrow, the brain, the thyroid gland, and the salivary glands. But when we're X-raying someone's abdomen, for example, we'd be looking at different structures, such as the colon, the stomach, the gonads. So the radiation effective dose could be quite different, even if we used exactly the same exposure factors and exactly the same X-ray machine. So how do we calculate effective dose? Well, it's the weighted sum of equivalent doses to different organs. So, in practice, we calculate the equivalent dose in sieverts to, for example, the brain, and multiply this by the brain weighting factor. We do the same for other organs and tissues within the path of the X-ray. For example, in a dental situation, this could include the thyroid gland. So we multiply the equivalent dose to the thyroid by the thyroid weighting factor. We continue with this process, adding on all the tissues that are relevant to the X-ray examination. And so on, until we've completed all the potential organs X-rayed in the examination. The sum of these is called the effective dose. It is still measured in sieverts. Remember, effective dose is really about risk. It's about equating the energy imparted to the patient to the biological risk. We've already covered a lot of ground, so why not have a little break now, perhaps go back and look at the slides again before we move on to the next part of this module. Previously, we've talked a lot about doses. It's time to put these into some kind of context. If I were to say to you, here is 1 sievert of radiation, I expect that you wouldn't know what I meant. We have no context in which to consider it. Well, here is such a context. All of us each year are exposed to radiation from a multitude of different sources, much of it naturally occurring. Here's an example in the United Kingdom where, on average, the citizen is exposed to 2,600 microsieverts per year. That's millions of sieverts. Obviously, the sievert is quite a big unit. So generally speaking, when we're talking about effective dose, we use millisieverts, thousands of sieverts, and microsieverts. When we look at this microsievert for the UK population as an example, we'll see that the naturally occurring radiation comes from, as I said, several different sources. Cosmic radiation from outer space contributes quite a lot to this annual average dose. Naturally occurring gamma radiation from the rocks contributes another significant component. Internal radiation from ourselves contributes another chunk of radiation exposure. A very large contribution in the United Kingdom comes from radon gas and its decay products. However, man-made radiation contributes about 300 microsieverts per year to our annual average dose of radiation in the UK. Remember, these figures will be different for different countries in Europe and throughout the world, depending particularly on natural radiation sources in the environment. Similarly, in some countries where the use of X-rays for diagnostic purposes is greater, the amount of man-made radiation will be considerably higher. This is the situation in the United States, for example, due to the large use of CT scanning. Let's turn now to the risks from exposure to X-rays. Earlier, we explained how X-rays could damage important molecules within the cell, particularly DNA. What are the consequences of this if DNA is damaged? Well, the overwhelming majority of the time, the DNA simply is repaired and nothing happens. If sufficient damage is made to the cell, then the cell could die. Now, if this is just a single cell in an organ, probably no clinical effects are likely to occur at all. Indeed, significant numbers of cells might die with no clinical effect. And we really only worry about cell death with extremely high doses of radiation. The third possibility is that the DNA is altered into a mutation, and that can have long-lasting effects. So it's mutation that we're particularly concerned about. Here's an unusual picture. This is the hand of a radiographer. This radiographer worked in the middle of the 20th century and had a practice, a bad practice, of using themselves as a test object to test X-ray equipment. They used their hand. Here you see a very striking effect of exposure to radiation in a normal diagnostic context, but where the practitioner was following abnormal and incorrect practice. The adverse health effects of radiation exposure can be divided into two types, with rather difficult names: deterministic and stochastic effects. Let's look at deterministic effects first of all. These include a whole list of things, and this is not a complete list, which may be associated with exposure to radiation. Erythema of the skin, loss of hair, reduction in bone marrow cell production, the formation of cataracts in the eye, and really all those things that are associated with radiation sickness, for example, in people that have undergone very high exposures in the atomic bombs and in nuclear accidents. These deterministic effects are in a large part due to killing or malfunction of cells following high doses of radiation. All of these effects have a threshold dose below which they cannot occur. But for the different effects, these thresholds are different. Once the threshold dose is exceeded for any particular effect, the severity of that effect increases. And recovery processes do occur. Here are some doses of radiation that are threshold for some of these deterministic effects. You'll notice cataract at the bottom, where the equivalent dose is 1.5 grays. This is all very interesting, but does it have any relevance to dental work? Well, the answer is it should never have any relevance to dentistry, because these radiation doses are all extremely high. Let's turn to stochastic effects, a rather odd term, and in some ways it's easier to substitute the term chance for stochastic. So these are chance effects. This includes two things. First of all, cancer development in exposed individuals because of a mutation of cells in the body, somatic cells. It also includes inheritable disease in the offspring of someone who has been exposed to radiation due to mutation of reproductive cells. In other words, putting it simply, we have two possible stochastic effects: cancer induction and genetic effects. As we'll see in practice, we ignore genetic effects in dental radiology because unless we're doing something very improperly, we do not irradiate the gonads. So this leaves cancer induction as our main risk. Incidentally, the image on the right is a cutting from a newspaper where the cancer cases attributable to X-ray exposure have been commented upon in the popular press. How do these stochastic or chance effects differ from deterministic effects that we looked at earlier? Well, there is no known threshold dose. In other words, any dose of radiation could cause damage. As we increase the dose of radiation, the chance of that effect occurring increases. And there are no known recovery processes. It's this lack of a threshold dose which is of major interest to us in terms of radiation protection. So, stochastic effects really concentrate on cancer manifested in the patient or indeed in a member of staff who has been exposed to radiation as part of their work. And the history of radiology, both general radiology and dental radiology, is littered with cases of individuals who have suffered these effects as a result of X-ray exposure. As I said earlier, genetic effects do count as stochastic effects, and they're manifested in the offspring of the person irradiated. And while these are believed to occur in association with such events as the atomic bombs in Japan, they are not considered to be of relevance to dental radiology. Despite what we've said about cancer risk from X-ray exposure, some people still doubt that there is a real risk, particularly at the low levels of dose associated with clinical medicine and dentistry. The relationship between cancer risk and radiation dose is believed to follow a straight line. However, evidence for this straight line relationship is quite weak for low dose exposure to radiation, particularly where we're dealing with doses below the level of 100 millisieverts. The International Commission on Radiological Protection does, however, recommend that we should assume a straight line relationship persists down to 0. This is called the linear no-threshold model. Other models exist, and for example, the French Academy's report of 2005 felt that it was unable to support the linear no-threshold model and cast real doubt on whether there was a cancer risk that was real at doses at this low level. Nonetheless, the ICRP, the International Commission of Radiological Protection, believes that the linear no-threshold model, in other words, no safe dose, provides a prudent basis for the practical purposes of radiological protection, that is, the management of risk from low-dose radiation exposure. Incidentally, the probability coefficient for cancer risk is believed to be 5.5 times 10 to the minus 2 per sievert. In other words, 5.5% per sievert. Let's move on to the risks from dental radiography. We've said that if we accept the ICRP point of view, that there is no safe dose of radiation. But as I also said, real evidence for increased risk of cancer amongst patients exposed to low doses of radiation is very weak. There are, however, a number of studies published in the literature that give some evidence to suggest that, for example, dental radiography is associated with an increased risk of some cancers around the head and neck, notably the brain, the salivary glands, and the thyroid gland. One thing we haven't considered is the risk of cancer and age of the patient irradiated. It's very important to understand that when we give numbers for risk associated with X-ray exposure, we do so assuming an individual is aged 30 years. Starting from that point, if you're younger than that, then the risk is higher. And this is up to 3 times as great a risk if the individual is 10 years or younger. This is why we protect children very, very carefully in the context of exposure to X-rays. On the other hand, older patients get a gradual reduction in their risk from exposure to X-rays, so that by the time someone is 80 years of age, it is believed that the risk from X-ray exposure in terms of cancer is negligible. Are there other risks from X-ray exposures? We've talked about cancer risks, we talked about deterministic effects. Let's just specify a particular problem that concerns many individuals, and that is X-raying a pregnant woman and the possibility of effects on the embryo and fetus. A number of possible effects are believed to occur if X-ray exposure occurs to the embryo or fetus. Malformations of development may occur, but are not believed to occur below 100 milligray exposures. Mental retardation may be an issue, but requires a dose threshold of at least 300 milligrays. Effects on IQ following in utero doses under 100 milligrays would be of no practical significance. And in terms of childhood cancer, the similar cancer risk is believed to occur to that of a young child, that is 3 times the population as a whole. X-rays may be associated with the induction of other diseases that are not cancer related. For example, in Japanese atomic bomb survivors, there is an increased incidence of heart disease, stroke, digestive disorders, and respiratory disease. And there is a considerable uncertainty still over whether these are stochastic or deterministic effects. The ICRP says that the data available do not allow for their inclusion in estimation of detriment following low radiation doses less than about 100 millisieverts. So in terms of dental exposures, we can safely ignore this effect. We've now reached the end of this PowerPoint presentation, so it's worthwhile to just recap on some of the key points. First of all, the risks from low-level radiation exposure are believed to be stochastic in nature. Remember, stochastic means a chance effect with no known safe radiation dose. Most authorities propose that the risk is directly related to the radiation dose. In dental radiology, because we can exclude genetic effects as a risk, our sole concentration is on the risk of cancer. The risk is believed to be higher in children and lower in the elderly. That concludes this module, and we must acknowledge the support received from the European Atomic Energy Community's 7th Framework Programme under the grant agreement for Sydentex CT.